sat here shivering in our freezing room for the last several hours. I now appreciate talking about cardiac arrest and hypothermia. I'm Shane. I'm one of the PGY1 EMIMs. And so we'll be discussing, let's see how to make this a little bit bigger. So we'll be discussing hypothermia, the different stages, complications, and some pathophysiology. We'll be discussing changes in airway management, BLS, ACLS changes, some rewarming techniques, and some causes or risk factors for hypothermia and its workup. There we go. So the vital signs don't really change in a predictable manner as the temperature changes. It can change based off of your age, race, gender, whether or not you're intoxicated, or any other medical comorbidities. You can have some people who have vital signs and they could be 66 degrees, and you have other people that can go into cardiac arrest around 90 degrees. The Swiss staging model is meant for pre-hospital providers so they could help kind of assess and triage patients based off hypothermia. But we can also use it too. And so going through the different stages, we have stage 1, and so this is where you have your shivering patient. They won't be altered, they'll have vital signs. We'll go on to stage 2, where they will become altered and their shivering mechanism will go away. Stage 3 is will be unconscious and they'll maintain vital signs. And stage 4 is when they're essentially frozen. So these are our cardiac arrest patients, and these are the ones that we're most interested in right now. So the different complications, so with regards to the heart, as they become colder initially, there'll be an increase in oxygen consumption as the body begins to shiver. Eventually they'll become tachycardic as the sympathetic nervous system revs up, and they become hypertensive as they peripherally vasoconstrict. As a patient gets colder, depolarization will slow the conduction of the heart, and then their heart rate will actually decrease in a more linear fashion. There's something called rescue collapse, where the cold myocardium is very irritable, and what ends up happening is any sort of jostling of the patient can precipitate a cardiac arrest or a malignant arrhythmia. And it's not necessarily something that we did, it's just kind of a natural course for the disease. And below 77 degrees, these patients can spontaneously go into VFib or asystole. This further gets complicated by other changes that happen during hypothermia related to volume, the electrolytes, pH changes, and their oxygenation that affects cardiac conduction. With regards to peripheral changes, we have A, which is just a normal room temperature room, and B, which is a colder room. And you can see there's decreased blood flow and heat going to the rest of the hand. And this is to specifically address core temp after drop, where the idea is that as the body peripherally vasoconstricts, you have a bunch of cold and acidic blood that pools inside the extremities. And as you start to rewarm them, that cold acidic blood then returns to central circulation and can cause a decrease in temperature and can cause that acidic blood to precipitate dysrhythmias. There's a little bit of controversy as to whether or not this is clinically relevant or even preventable. But the recommendation is that we warm the core before the periphery just to avoid this from happening. With regards to the lungs, so a couple of things happen. There's essentially brainstem failure in terms of initiating ventilation, but at the actual lung, I think it's easy to conceptualize that the lung actually becomes frozen. So you get some ciliary dysfunction, and so that can cause frothy sputum, viscous sputum. There's some cold bronchorrhea that happens. Non-cardiogenic pulmonary edema can develop. You can also get ARDS. Then the actual lung can become less compliant. The thoracic wall will become stiff. And then the muscles of respiration are our diaphragm and our intercostal muscles. They contract less efficiently at colder temperatures. So they essentially create a VQ mismatch as the ventilation fails. When it comes to the kidneys, what can happen is essential hypervolemia. As we peripherally vasoconstrict, you'll have more blood going to the kidneys, creating what's referred to as a cold diuresis, where patients essentially pee a bunch. But that doesn't necessarily mean that the kidneys are working better. There's a little bit of dysregulation that happens at the kidneys, so they aren't going to be clearing medicines or even toxins that well. The other issue that can happen with the kidneys is rhabdo. As we peripherally vasoconstrict, there'll be less blood going to our muscles, causing cell death, and that can lead to AKIs, renal failure, and other electrolyte disturbances like hyperkalemia. Lastly, we can get a cold coagulopathy. So a couple things can happen. We can become hypocoagulable. That occurs due to bone marrow suppression, hepatic sequestration, and splenic sequestration of our platelets. We can also become hypercoagulable, and the reason that happens is very similar to DIC. The mechanism is not entirely understood, but we do know that these patients are more likely to clot. Let's see. And then, the last part is that for every 1 degree drop in Celsius, you'll have a 2% increase in hematocrit. Then that is made worse by the fact that these patients are diuresing themselves, and so they'll become hypovolemic and hemoconcentrated. So when it comes to CPR, we should be initiating CPR as soon as we realize that we should be initiating CPR, even before rewarming. And so some of the changes to BLS, we'll want to increase the time at which we check for a pulse. That's because of bradycardia and peripheral vasoconstriction that might make it difficult for us to feel their pulses. We should also be using our adjuncts like ultrasound and cardiac monitors to determine whether or not we can see any sort of electrical activity, or whether or not we get actually visualize the heart squeezing. We should also be affixing things like our Lucas machine. These resuscitations can go on for hours in some cases. And then typically when we talk about BLS, we talk about circulation, airway, breathing. But in our hypothermic cardiac arrest, we should be adding a T, so CABT, and that's because we should be, as they come in an arrest, we should already be thinking about where they need to go, which is a center with ECMO. When it comes to shocking the patient, what's most important is that we rewarm the patient. Most of these patients, if they go into dysrhythmia, those dysrhythmias are not going to cause any sort of hemodynamic instability, and they're going to go away as we rewarm them. Defibrillating in and of itself is a little bit controversial, mostly because the AHA recommends no changes at all to our ACLS algorithms. If you talk to experts in Canada or the ERC, so the European Resuscitation Committee, they'll recommend that we wait until about 86 degrees before we start shocking patients. And that's just based off of case studies that have had successful defibrillation. I'm sorry, I misspoke. They recommend that you don't try to shock more than 3 times, and then you should wait until 86 degrees. We should avoid pacing bradycardia in these patients, mostly because it's going to be physiological because of the hypothermia. It's not uncommon for them to go into atrial fibrillation or bradycardia, and in some animal models, it's been shown that that could actually precipitate VFib arrest. If you've rewarmed the patient all the way and they're still bradycardic, that's when you can consider rewarming them. So some changes in our body's metabolism of medications when it comes to hypothermia. And so we really want to avoid oral medications. That's because of the decreased function of our GI tract for them to actually become absorbed. We're also going to have decreased functioning of our liver and our kidneys. And so we should also be avoiding IM medications. And that has to do more with the fact that we're peripherally vasoconstricted in hypothermia. There's erratic absorption for the musculature, and we really can't predict its effects. Medications also tend to be temperature dependent. Proteins in our body tend to bind more medication at colder temperatures. And so a lot of the medications we'll be giving won't be available to the patient. The flip side of that is that as we rewarm them, more of that medication will become available to them, and we could paradoxically cause medication toxicity. So when it comes to what should we do for our patients, we should still be giving epinephrine. And again, controversial, because the AHA recommends that as soon as we see them and we think that there's an indication for epinephrine based off of our ACLS algorithms, we should give it. The ERC, on the other hand, they think that we should wait until 86 degrees. And even between 86 and 95 degrees, we should be doubling the length at which we give it. So instead of 3 to 5 minutes, it's 6 to 10 minutes. And then above 95 degrees, we should be returning to our ACLS algorithms. With regards to things that we shouldn't do, we kind of already discussed the fact that we should not be giving IM or PO medications, but also we should be considerate of the use of vasopressins or things that will constrict the peripheral, or the periphery. The reason being that just because of the pathophysiology associated with hypothermia, a lot of times these people are maximally constricted anyways, so you're really not going to get much squeeze out of them. As you vasodilate and warm the patients, you can consider it, but if they have frostbite, then you might precipitate digital ischemia. And while limb is more important than life, life is more important than limb, it's just something to be considerate of. And so we should be taking the airway in these individuals. The reason being, we discussed a little bit already that they'll have some cold-induced bronchuria, they'll have viscous secretions because of decreased ciliary function, but also as they get colder, they'll lose their airway reflexes. And so this is a way of protecting the airway. It'll also allow us to monitor their temperature with esophageal probes. And there's an element of atelectasis that comes along with the hypothermia, and the intubation will allow us to control for that VQ mismatch. We should be avoiding our neuromuscular blocking agents for a couple of reasons. One is a lot of times these patients, if they're cold enough, will have cold trismus. So essentially their jaws are frozen. And so the paralytics are not going to help with that. The other reason is that as we're trying to warm our patients, we're going to want to know if their mentation is improving. And the RSI medications, metabolism and clearance is going to be affected by the fact that they're hypothermic. And so it would blunt our ability to do that. We rewarm the patients, they're going to start shivering. And as they start shivering, they're going to need more oxygen. So an intubation allows us to control the amount of FiO2 that they're getting. And lastly, if we have the ability to, and we have noticed that they have cold trismus, we should be looking towards fiber optic intubations. The reason being that a nasotracheal intubation or a crike, because of the cold coagulopathy, they could end up with major epistaxis and bleeding. So this is just elucidate that these things can take a while. The prognosis of a patient, as long as they get transferred to ECMO, doesn't really matter how long the CPR goes on for. A patient who gets CPR for 4 hours versus an hour before transitioning to ECMO, there's no real difference in how well they do. What's most important is that they get transitioned to ECMO. And then with regards to when we stop the CPR, patients will come in hypothermic and then they'll look like they're in rigor mortis. They could have fixed and dilated pupils. And so you really can't depend on that to tell you whether or not they're truly dead. You can go ahead and, if you're if the labs that you drew initially showed a potassium greater than 12, that's been considered to indicate a futile resuscitation. But initially it was 8, and then it was 9, and then they resuscitated a patient with a potassium of 11.9 and changed it to 12. So who's really to say? When you rewarm them, our goal should be to get them to that stage 1 hypothermia where they'll have vital signs, they'll be shivering, and if they don't have a pulse at that point, then they're probably dead. So everything that we do is really a bridge to the ideal rewarming technique in our patients, which is ECMO. ECMO is going to restore the circulation, maintain tissue oxygenation, remove carbon dioxide, and allow for fast and controllable rewarming. The number needed to treat for a person with hypothermic cardiac arrest is about 2. And the survival rate in ECMO centers for hypothermic cardiac arrest is somewhere between 50 and 85%. And in centers without it, it's somewhere between 10 and 15%. With regards to the things that we have available here, we have our active rewarming, internal rewarming. So we can use our 5-lumen catheter. That's the heat exchange Zoll catheter we have available. If they're intubated, we can provide humidified air. And then lastly, we can always do the external rewarming with hot packs of the axilla or the bear huggers. And so ideally, we'll be transitioning these patients to ECMO anyways. We really shouldn't be, if we can get them somewhere within 6 hours, that's what we should be doing. But if you're somewhere where you can't do that, then we can focus on the lavages. So we have our gastric or bladder lavages. We can use chest tubes to do thoracic lavages. And we also have our peritoneal lavages. And so in terms of risk factors for hypothermia, you can kind of think about them in different buckets. So we have things that increase your heat loss. So that's things like environmental exposures. There's certain medications or toxins like alcohol that can increase your heat loss. Some certain skin conditions like burns or psoriasis can cause you to become hypothermic, or even overzealous treatment of hyperthermia can cause hypothermia. We have things that impair our thermoregulation. So these are peripheral failures to thermoregulate at the skin level. So things like diabetes, if they have peripheral neuropathy, things like spinal cord injuries. And there's also central causes as well. So things like MS, certain medications like SSRIs and SNRIs, or even strokes or subarachnoid hemorrhages can do it. Most importantly, though, it's hypoglycemia, and that acts at the level of the hypothalamus. Next, we have things that decrease our heat production. And so this classically happens in patients who are hypothyroid or they have some element of adrenal insufficiency. If they're malnourished and they just don't have enough fuel to generate enough heat, or if they're deconditioned, as with our elderly population. And then the last bucket is just kind of like other stuff. So things like lupus, sickle cell, uremia, pancreatitis, sepsis can do this, and our polytrauma patients can also become hypothermic. So in terms of our workup, what are we going to do? A lot of our patients are going to have other things going on, mostly because we don't live in Canada and we don't have a lot of avalanche patients. And so what's most important that we do up front is we check for blood glucose because of what I had mentioned earlier about the hypothalamic failure. And then after that, as long as you draw rainbow labs, for the most part, you're going to be able to catch everything that could potentially cause hypothermia. It'll allow us to get our CBC. If they're anemic or they even have like a normal hemoconcentration, they will be hemoconcentrated anyways. So if they have a normal hemoglobin, that might indicate they're bleeding somewhere. We'll get our coags. We'll be able to check for DIC by checking fibrinogen. We can get our cortisol and our TSH. We can add a lot of these things on even if we forgot initially. And then we can get our blood cultures if we're worried about sepsis. And then lastly, we can do our CT head to do our altered mental status workup or to check for hemorrhagic strokes. We can go ahead and get our chest x-ray if we're worried about non-cardiogenic pulmonary edema, if we're worried about trauma or pneumonia, and we can get our pelvic x-rays if we're worried, just to complete our trauma survey. So overall, we've kind of talked about the different stages and how they can help us, but really it's the stage 3 and stage 4 that are at risk for the cardiac arrest. We talked about some changes in our ACLS and BLS to include the prolonged CPR. We should be affixing the mechanical compression devices. And really this is just to get them to ECMO. And if you forget all the changes in ACLS, then that's fine because the AHA says that's what you're supposed to do anyways. Control the airway, IV meds only, and make sure we're looking for secondary causes. But again, if you forgot exactly what labs you're supposed to draw, just get everything and it'll cover whatever it is that you might have to add on later on. So that's my spiel.
I know it's like super late. First of all, way to go dedicated on the frozen thing.
Thank you.
And let's be honest, most of them have bones. Okay, so
Yeah.
you're gonna have to deal with that in that last slide.
I mean, have you gotten an x-ray of him?
I know. I've actually had several hypothermia patients over the years where I've had to do active REWARMING. ECMO, I think, really is the way to go. I haven't. The challenge of not being an ECMO center is it's a big challenge. Because sometimes the patient feeling ECMO, they might be hesitant, and if you call deep into the resuscitation, it might already be too late. So if you have a significant unstable hypothermia patient, one of the first things you're doing, besides obviously doing the resuscitation, trying to rewarm as fast as possible, is really calling in an ECMO center to try to establish that. And my last hypothermia patient came in at 79, and we were actually able to rewarm her up to the low 90s within a few hours with just a bear hugger, warm fluids, and a bladder irrigation.
That was terrific. That was really terrific. One of the best presentations of this I've ever seen.
Oh, thank you.
The slides are amazing.
Yeah. And you knew your presentation, both of you were great. You memorized your presentation, you made great eye contact, great gestures. You didn't have to read from the slides. Both of them were great.